Now coming to the intraoperative period. Okay. Here the most important thing is the surgeon is going to deal with the pathological lung, the destroyed lung, and he is going to remove the lung. Anesthetists have to deal with the normal lung. It is going to be very difficult. When you deal with physiology, you can't afford to do a mistake. That is very, very important. If you do a mistake, it will automatically go into pathology. So, you have to be very careful, and the margin of error is very, very minimal. And what are your concerns? Here, first thing is you have to isolate the normal lung properly so that the saturation, other thing is maintained. And patient is going to be in lateral position, and what are all the hemodynamic effect and nerve and vascular injury which is going to happen in the lateral position, you have to take care of. Thoracotomy. Thoracotomy is one of the painful procedure, and you have to give a proper analgesia when patient is undergoing thoracotomy. As I said earlier, the most important challenge is isolating the lung by proper placement of double lumen tube, and there is going to be hypoxia, and HPV can be protective, and you have to be very careful not to abolish it. Fluid management is very, very important, and you have to give a good analgesia. Now coming to the physiology of one lung ventilation. Normally, the right lung is slightly, this is the right and this is the left. Right lung is slightly more voluminous than the left side. So, with regard to perfusion, little bit, okay, 55% goes to the right lung and the left lung receives around 45%. But with regard to ventilation, both receives equal amount of ventilation. This is in the normal supine position. So, there is nothing much major shunt or dead space, and equally the ventilation perfusion is matched. So, there is no hypoxia or shunt or dead space. This is the normal supine position. Here the black one is the air and the red one is the blood flow. Both are ideally maintained. Now, if the patient goes into the lateral position and closed chest, as usual, due to gravity, the right side is going to receive even more blood, and the left side, because it is on the non-dependent part, your blood flow is compromised little bit. But with regard to ventilation, here you can see the ventilation on the non-dependent lung is going to be better, but in the dependent lung, the ventilation is going to be slightly less. So, what is going to happen here? The right lung is going to receive more blood flow and the left lung is going to receive more ventilation. Here, the dependent right lung contributes more to shunt, and you can expect little bit of saturation to come down. Now, coming to the most important part, which is the open chest lateral position, and you isolate the lung, which is the operating lung. The non-dependent lung is isolated. So, there is no ventilation going into the left lung. All the ventilation goes to the right lung. With regard to perfusion, right lung receives more perfusion than the left lung already, and the blood flow will be diverted to the right lung. But still, you are not occluded the pulmonary artery. So, the blood can go into the non-dependent lung. So, the hypoxia can get worsened with this scenario. Here, the left lung contributes to majority of shunt and the right lung receives majority of blood flow. The non-dependent left lung receives only 25% of blood flow, but the entire ventilation is going to go only to the dependent right lung. To summarize what happens in lateral position, the dependent lung perfusion is always greater than the non-dependent perfusion. The ventilation before collapsing the lung, the non-dependent ventilation can be greater than the dependent lung ventilation. But once you collapse that non-dependent lung, it is going to aggravate your hypoxia further. As you move from awake anesthetized to open chest, your hypoxia is going to